Alrighty, we're going to go and get started. Good morning. Thank you for being here for our cardiology and pulmonary joint grand rounds this morning. My name is Suraj Mishra, one of the chief cardiology fellows here. And today I'm especially pleased to introduce our speaker, one of my own close mentors, Dr. Anjali Vaidya, as our Diane C. Wallerstein lecturer. To tell you briefly about the lectureship, the Wallerstein Endowment was established through a generous gift by Diane's husband, Ben A. Wallerstein, and her children, Nancy Wallerstein Miller and James Wallerstein. It was our family's intent to memorialize the life of their beloved Diane by creating this legacy that will support education of medical students, faculty, and researchers here at VCU. Now to our speaker, Dr. Anjali Vaidya. She's a professor of medicine and co-director of the Pulmonary Hypertension, Right Heart Failure, and CTEPH program at Temple University School of Medicine. Since her recruitment in 2016, they have grown to be one of the largest PH, CTEPH, PTE, and BPA programs. You'll learn those acronyms here shortly in the United States. And she has developed an international reputation speaking and educating in pulmonary hypertension and CTEPH. She serves as a founding director of the Temple's Pulmonary Hypertension Fellowship, one of only few in the nation, and associate program director of the Cardiology Fellowship and also the Internal Medicine Residency at Temple. She's a recipient of Temple Health System's Educational Excellence Award for Educational Service, Educational Excellence Award for Graduate Medical Education, Mentoring Award for Women in Medicine and Science, just to name a few. She joined Temple after serving as co-director of PH and APD of the IM residency at University of Pennsylvania, where she received the Donna McCurdy Department of Medicine Teaching Award. She's published over 50 academic articles and book chapters and nearly 100 abstract presentations at medical symposia. I'm truly honored to welcome Dr. Anjali Vaidya to VCU. We're grateful for her expertise and look forward to learning from her today. At the end of the lecture, we'll leave some time for questions. And if you're tuning in via Zoom, feel free to drop them in the chat function as they arrive. We're pleased to offer both CME and MOC credit for our Grand Round Conference Series. To claim credit, you may text the code shown at the beginning and also be shown at the end of the presentation. And thank you. Dr. Vaidya.
I appreciate it. Thank you so much. That was a very kind introduction. Good morning, everyone. I'm really honored and happy to be here. There's a lot to get through, so we'll just kind of jump right into the topic on chronic thromboembolic pulmonary hypertension. These are my disclosures. My biggest one is my apology that the airline changed my flight to 2 hours before it was supposed to be. So I don't normally speak and run, but unfortunately, I'm going to have to do that to try to catch my flight. So I do apologize in advance if I can't stick around for too long after we're done. But I wanted to start just to kind of get our appetites wet for the kinds of cases and clinical scenarios we're dealing with just by describing a patient that was referred to us. This was a 38-year-old gentleman, a firefighter, BMI of 47, very sick, functional class 4, had a history of antiphospholipid syndrome. He's been having PEs for many, many years, even so far as a clotted IVC filter. We're currently admitted for dyspnea and severe decompensated heart failure. Was found to have pulmonary hypertension, not just pulmonary hypertension, but on imaging noted to have what looked like a calcified mass actually obstructing his tricuspid valve, had developed likely right heart failure mediated cirrhosis, was thrombocytopenic as a result of all these complications. His hemodynamics were profoundly impaired with reduced cardiac index and severe right heart congestion, and was at the point of being offered hospice care. So just to flavor an example of the kinds of cases that sort of come our way in this topic. So we're going to talk about chronic thromboembolic pulmonary hypertension, and goals for today. There's a lot we could talk about, and I'm going to try to give you an overview of the pathogenesis, epidemiology, some of the risk factors. I want to bring to your attention sort of a novel category that I'll get into that I've coined the term mechanical risk for CTEPH. We'll talk about the diagnostic evaluation because it's very complex in these patients, and then getting into treatment options, which include surgical pulmonary thromboendarterectomy, that's PTE, balloon pulmonary angioplasty, BPA, combination with medical therapy, and very briefly, I just want to highlight at the end other clinical conditions that can mimic CTEPH that are just important to be aware of. So this is a form of pulmonary hypertension, and I'm sure all of you are familiar with the World Health Organization diagnostic groups. There are 5, and they're listed here, and I won't go through all of them or read through all of them with you in detail, but just as a kind of get ourselves oriented and reminder, WHO group 1, that's the pulmonary arterial hypertension that folks kind of think about when you think about the term pulmonary hypertension. But what we're focusing in on today is actually WHO group 4, which is pulmonary hypertension due to chronic obstructions and most commonly thromboembolic disease causing those obstructions. Just you'll see a few examples of what those chronic obstructions might look like over the course of the morning. Now, clinically, these can look very similar. Oops, I think my echo here, see if we can get that to play. But the point of these two images side by side is hopefully you can't discern any major differences between these two hearts. And that's sort of the point. And so while CTEPH is a diagnosis in and of itself, and it has this whole different algorithm of diagnostic evaluation and workup, the presentation clinically, hemodynamically on echo Doppler can look very similar, if not identical. So we always say a patient doesn't have WHO group 1 pulmonary hypertension until they've been ruled out for CTEPH. And of course, that will be done with the EQ scan, and I'll talk about that in a minute. So chronic thromboembolic PH, what is the pathophysiology? How does this happen? Of course, acute pulmonary embolism is one of the most common medical conditions that land people in the hospital around the world. And so patients might have, of course, venous thromboembolism leading to PE. And in a small percentage of folks, there's just incomplete resolution of that thrombus. It can lead to obliteration or occlusion of the pulmonary arterial circulation, ultimately leading to high pressure, shear stress, and actual vascular injury as a result over time. And it could lead to a progressive increase in pulmonary vascular resistance. And then therein lies the chronic thromboembolic pulmonary hypertension and ultimately right heart failure. Very common question is, well, what are the chances of PE? Or the epidemiology is so high. What are the chances to develop chronic PE if you've had acute PE? We quote the PANGO data all the time. You'll hear this quite a bit. This is now 20 years old. It's kind of hard to believe. This is a paper that came out looking at folks prospectively having had acute PE over several years, hundreds of patients, and ultimately concluding that about 4% or so of patients are at risk of developing chronic PE after acute. In the literature, you'll see a range of data estimating maybe as high as 5, 6, or 8%. It's probably a bit higher than what was recognized 20 years ago. We know that it is based on just awareness. But at that time, they identified risk factors for developing chronic PE. If your PE was idiopathic, we don't know why it happened. If you were young at the time that it happened, you were more likely to develop more over the course of your life. If you had a very large perfusion defect at the time of your acute PE, that was also more likely to develop into chronic clot. Or of course, if you had had a prior history of multiple PEs as well. This paper came out years later, and I just wanted to show the important difference between patients that have had a history of one first acute PE versus if once you've had more than one PE, this is just one of many kind of papers in the literature showing that your risk is exponentially increased. Once you've had more than one PE in your history, the chances of developing chronic PE or PH as a result of chronic PE as the diagnosis becomes much higher. And this always reminds me of the clinical distinction of patients when they present to us with a history of recurrent acute PE. Just keep in mind the possibility that sometimes it may in fact be recurrent acute PE, but very often what is not recognized is an acute clinical presentation of a patient with worsening chronic PE, meaning their PH and right heart failure are getting worse. And on serial imaging, more PE is sort of recognized each time, but the clinical presentation can be quite acute in the dyspnea and kind of right heart failure syndrome. Matsubara, I'll show more of his literature to come, but this is a nice paper where he describes some of that actual pathology, where you can see organized thrombus, real thickening and fibrous intimal hyperplasia, similar to what you would see in pulmonary arterial hypertension. But organized thrombus, it really does integrate with the actual vessel wall and the intima. And then these colander lesions have been described, which are these partially recanalized channels. So this is what it would look like kind of on the cross section. So now in the kind of the current era, there are these categories of risk for folks that are likely to develop chronic PE or CTEPH. And I've alluded to some of them already. Their categories are what I call sort of the PE specific risk. We sort of talked about the folks that have had recurrent PE, so unprovoked. We're not clear what the etiology is. They were young at the time and they may have had significant pH noted already at their initial PE. Then there's the medical conditions that won't surprise us either, folks with underlying malignancy, folks that have indwelling venous access, whether it's a port for prior chemotherapy, even our cardiology patients with pacemakers and defibrillators, they are at risk for really small thrombus and can have difficult to diagnose distal thromboembolic disease. We've certainly seen that. And then the hypercoagulable patients, of course, are a big part of this population. I mentioned my case earlier with the antiphospholipid lupus anticoagulant. That syndrome it's a predominant kind of comorbidity from a hematologic perspective in terms of risk for developing CTEPH. It doesn't have to be these categories, however. And for all of those patients that we've all seen, and since we were in medical school, of unprovoked PE or unprovoked DVT, and I don't know about you, but my understanding was always, well, there's probably some hematologic condition that you have, but we just don't know what it is. But clearly, you know, you as a patient individual have demonstrated a risk for having this, and we're not clear why. There's this category that we've described and sort of recognized at Temple, and this is what I'm calling the mechanical risk, anatomic mechanical risk. This is a CTEPH mechanic cartoon that I invented to try to just think about the venous risk of clot, and part of that being stasis and compression of veins. And so I'm going to show you a few examples of that. Years ago, we published this case series. We've seen dozens of cases since then. But for example, we had a group of women in our CTEPH population, seemingly with unprovoked recurrent PE. None of them had a hypercoagulable state. And we sort of recognized this pattern that a really significant percentage of them happened to have a history of significant large uterine fibroids. On imaging, we were actually able to demonstrate that these fibroids were compressing their pelvic veins. Notably, most of them underwent hysterectomy and then never had recurrent venous thromboembolism again. So really hypothesis generating. And of course, just remembering that oftentimes fibroids will manifest with menorrhagia, which is often managed with estrogen. And so it does kind of add to that multiple hit phenomenon of why someone might develop recurrent venous thromboembolism. Just a couple of examples on the top left there. This is a case of ours of a patient pre-hysterectomy. Both images here, you can see significant narrowing of those iliac pelvic veins. And then the same case on the right after hysterectomy. This is direct catheter venography that we perform. And then on the bottom, just two different cases pre-hysterectomy showing that venous compression and narrowing. We have seen this with venography, intravascular ultrasound, and or CT or MRI imaging. I'm not talking about the 2 to 3 centimeter fibroids. We're usually about 7 centimeters or so. So did I ever think as a cardiologist I would be talking about this? I definitely did not. But it's just important to just have on everyone's radar. We all take care of dyspnea for a living. We all take care of women for a living. It is a very, very, very prevalent condition, and it is not something we often think to ask about. So please just keep that in mind as one of the many mechanical risk factors for recurrent venous thromboembolism and CTEPH. May-Thurner anatomy was something I remembered from first year medical school and then promptly never thought about again until I became a CTEPH cardiologist. So just as a reminder, this is a known anatomic variant where our left iliac vein is compressed by the overriding right iliac artery. And it can look like sort of this double barrel venous appearance on venogram here, but we published our experience of our patients with CTEPH that underwent pulmonary angiography and venography and noted about 30% of them, interestingly, had this anatomy. So just hypothesis generating of this association, a much higher prevalence of May-Thurner anatomy than the normal population. Of those, more than half of them had, importantly, the distinction of May-Thurner syndrome, meaning actual lower extremity DVT with residual kind of post-thrombotic syndrome in that extremity. So our patients with May-Thurner anatomy, you can see here, all of these were CTEPH patients, much more likely to have had lower extremity DVT. And interestingly, in our experience, much more likely to undergo PTE, which we'll talk more about. That's the surgery to resect the chronic clot in the lungs. my hypothesis there is that when the large proximal veins are involved with DVT, that's going to generate larger actual DVT, which is more likely to land a more proximal large PE, which then tends to be more operable and accessible. So just some more thoughts to hypothesize there. And in those with May-Thurner syndrome, this is something that requires further work, but we are looking at the potential of intervening with venous stent to try to mitigate that recurrent risk. So kind of on the forefront of recognizing this, describing it, and learning what the right interventions are and for whom. On a larger category, this really can all be kind of referred to as just pelvic vein obstruction. And uterine fibroids, May-Thurner syndrome, these are just two examples. When we looked at our whole series here, almost half of our patients with CTEPH had some form of pelvic vein obstruction, whether it was May-Thurner, or you can see just the range of different levels of venous involvement, bilateral, unilateral. These are just different venograms on the right, showing one here is a patient with their left external iliac vein compressed. Here's that right common iliac vein. There's a whole host of likely under-recognized aspects of pelvic vein obstruction that happen in our large population of patients with recurrent venous thromboembolism. And so just a category to think about in our sort of pathogenesis and etiology of the disease for all of those unprovoked idiopathic recurrent PE. Now, the diagnostic evaluation for CTEPH is very complex. I have this little puzzle. I think of this, and I often will say to my patients, you know, the reason you've traveled across the country and the reason there are a few centers that do this is because there's just all these layers of complexity. And part of that is the diagnostic evaluation. There are multiple pieces to the puzzle. Some tests will give you some elements of information compared to others, but it's really important to integrate all of them. The vast majority of cases, shortcuts are not going to be the right and smart thing to do in terms of skipping over certain modalities of imaging, et cetera. So let me kind of tell you what I mean. First of all, the clinical presentation I alluded to earlier, exertional limitations, no surprise, dyspnea, fatigue. A lot of clinical evidence of right heart failure. That's what pulmonary hypertension is. I always say PH is always heart failure. It's either a cause of right heart failure or a result of left heart failure, but PH is heart failure. And in this case, right heart failure. So peripheral edema, exertional chest discomfort, pre-syncope, syncope. You may actually have a relative absence of PH and have isolated ventilatory inefficiency simply from the vascular involvement of the chronic clots. And that may be evidence on cardiopulmonary exercise testing, which we do on all of our patients, that elevated VCO2 or the reduced end tidal CO2. So there's the clinical symptoms, the hemodynamic, heart failure presentation, and as well as the ventilatory inefficiency. So different mechanisms of functional limitation. The VQ scan. This has now become very ingrained in our medical education, even for students, but it was only until I would say maybe about 10 or so years ago that this started to catch on a bit. The reason that there's so much emphasis on the VQ scan, the ventilation perfusion scan in CTEPH, is because the sensitivity is much, much higher than the current standard baseline level of sort of training in radiology to recognize chronic clot on CT scan. So I'll get to that in a moment, but a relatively untrained or inexperienced VQ scan will pick up abnormality, and that sensitivity is very high. So the screening test is on your boards, and the teaching would be a VQ scan. Now, the CT and the CTA is really the component that will give you the most actual anatomic information. And I really like to correlate the anatomic distribution of perfusion abnormalities from the Q scan relative to now the kind of roadmap for treatment planning from the CT. Now, I always remind my cardiology trainees, don't forget to look at the lungs, and our pulmonary trainees, don't forget to look at the heart. There's so much to get from the CT scan. So the vascular structures, the RV, the RA, significant enlargement you might see, but really pay attention to the RV wall thickness. That can often give you a clue as to, is this acute versus chronic disease, which is often a question in interpreting thromboembolic disease on a CTA. You may see this sort of scarring, fibrotic, curvilinear abnormalities, which is very often interpreted as a consolidation, like an infectious process. So you'll hear patients give you a story of recurrent pneumonias and antibiotic courses that did not help them, but in fact, it's pulmonary ischemia or pulmonary infarct. You'll particularly see subpleural involvement there. On the right is this classic on a CT angiogram mosaic perfusion pattern of the lung. Well, you'll have this relatively normal perfusion area that looks kind of like a ground glass area, but it's abnormal. The abnormality is the relative areas around it of hypoperfused areas. So that mosaic perfusion pattern would be a sign also. Now, in terms of the actual angiographic component of the CT, there's a whole host of abnormalities that can give you clues. Webs, these are these kind of linear abnormalities that are that on the path picture I showed you, those partially recanalized lesions can look like these linear webs on an angiogram. You might just see lining thrombus along the vessel wall, and that can look like an intimal irregularity. It's much harder to pick up on that visually compared to acute PE, which is why we never miss acute PE on a CTA, but chronic is often under-recognized. In chronic disease, the clot really brings the vessel caliber down and it tapers. So you do see distal tapering or poststenotic dilatations. And then systemic to pulmonary collaterals, that's a whole nother conversation. We don't have time to get into more detail, but you may see bronchial arterial collaterals coming off the thoracic aorta and feeding the either lung, usually more likely to the right side. Those bronchial arteries are always there. We don't see them because the caliber is very small typically. So if they're notable visually on a CT scan, it means they're hypertrophied and they've evolved in response to chronic occlusion of the pulmonary arterial circulation. This is a nice paper by Deepagopalan that just shows this abnormality in venous return. So something we don't always pay a lot of attention to the 4 pulmonary veins coming into the LA if we're thinking about PE. But in chronic PE, you won't see this in PAH, but if you have diminished arterial outflow, you in a significant relatively proximal lobar or proximal segmental disease that's nearly occlusive, that could be so significant in diminishing your arterial outflow to a region of the lung that the venous return then will also be diminished on that side. So you may see actual absence of contrast filling in the significant one of the 4 pulmonary veins, or just real narrowing in that pulmonary vein relative to the other pulmonary veins. So that's a nice clue. Now, in terms of some advanced technology in the CT world, dual energy CT, just something to be aware of that we may be seeing more and more commonly used. This is helpful to acquire information for tissue characterization where you get 2 data sets acquired at multiple energy levels. So this is helpful because it can allow for evaluation of parenchymal abnormalities, the lung tissue, perfusion blood volumes you can see here, and it really does correlate with catheter-directed pulmonary angiography potentially in terms of noting large wedge-shaped defects in the periphery, but even subpleural abnormalities. So this is something to be aware of on the horizon that's being studied and used more and more. You'll hear and historically described the gold standard for diagnosis is the catheter-directed pulmonary angiography. I just want to come back to that original jigsaw puzzle to say that this is a very valuable part of the diagnostic algorithm, but it is not meant to skip or replace the use of the functional perfusion scan or the CT angiography, because this is simply a luminogram. It doesn't tell you all of the other data that the CT gives us, but very helpful. It's also very different in terms of technique to perform relative to the kind of more commonly used and taught, let's do a pulmonary angiogram to rule out, massive saddle PE, for example, in the cath lab, if somebody is having a clinical presentation that needs to be sorted out. To be really diagnostic and helpful, we have to use digital subtraction angiography, selective angiography of both lungs, maybe even lobar. There's very specific technique in terms of the pressure injections, patient cooperation with breath holds, and multiple planes of use, because as you all know, the pulmonary circulation is very extensive with lots of overlapping vessels. And so that's really important to get quality studies enough to be able to use them for CTEPH. So evolving in the CTEPH kind of journey, let's talk about treatment. We've made a diagnosis. We think we've acquired all of these pieces of data, the non-invasive and the invasive imaging. What are the treatment options? Could be for PTE, BPA, medication. We'll talk about all of those. But it's not just selecting the therapy. The management sort of pre and post-operatively or peri-procedurally is very nuanced. And we're learning more and more about the importance of long-term serial assessment even after these major interventions, because there's much opportunity for ongoing patient benefit. In our program, all of this is driven by the medical PH team. It happens to be cardiology in my program at Temple, but you're probably gathering how multidisciplinary this sort of disease is and should be and requires. But I do want to just emphasize the importance because it's so nuanced. It's really helpful and important for like a central medical, some part of that team to kind of have a sufficient comfort and expertise and awareness across the whole spectrum of these, because there's a lot of overlap in treatment modalities and what's appropriate to kind of make the right decisions. The guidelines in this disease are very clear that if a patient has suspected CTEPH, this is going to sound very silly, but they should be immediately referred to a CTEPH center. And I know we have a wonderful mix of cardiology and pulmonary, which I love here. And I'll speak from the cardiology perspective to say, on behalf of all of us, we are obsessed with guidelines and we use them in quite detail. And in the pulmonary hypertension guidelines, when I started doing this field, the guidelines literally just said, you should probably refer to an expert, like the end. And that was a little upsetting because I was like, well, that's me and I would like some guidelines. And the pulmonary hypertension medical guidelines have certainly evolved over the last 15 years. The CTEPH guidelines are getting there, but still at the core, it's if you suspect or recognize CTEPH, steps 1 through 5, just get to an expert CTEPH center, not PH necessarily, but CTEPH, they're very different. And so we're making progress, but it's just worth noting. And part of that is because there are medical therapies available, but very clearly the use of medical therapy should not delay referral because it is not meant to replace a more kind of sophisticated intervention like surgery or balloon pulmonary angioplasty. Most CTEPH is actually operable and should be operated upon, and then we'll get into more and more sort of the alternatives. But with the gold standard and the preference being PTE, pulmonary thromboendarterectomy, the decision for this is very complex and it's hard to summarize on a slide or even a few slides, but I want to try to give a framework for how to think about this conceptually. Is the patient has CTEPH, are they a candidate for this surgery, pulmonary thromboendarterectomy? On the right is everything I described earlier. They should have enough of a clinical abnormality, functional limitation, or objective evidence of either hemodynamic or ventilatory impairment on the basis of chronic thromboembolic disease in order to justify going down this road. This sounds maybe obvious, but in our real world of multifactorial dyspnea, the presence of chronic PE in the context of dyspnea does not imply causation. So you have to sort of ensure that the degree of thromboembolic disease is causing the degree of functional impairment such that the patient will derive benefit from undergoing this intervention. Along those lines, at the top of the screen, does the patient have an advanced pulmonary hypertension, secondary arteriopathy from any other cause that is not thromboembolic disease? Do they also happen to have idiopathic PAH or scleroderma or something else? I always say every patient in the world is well within their right to develop an acute PE, even if they have other medical diseases, and that may lead to chronic PE. It doesn't always mean that their PH is wholly related to entirely the chronic PE that you see. There's a lot of mimics that I'll just go over later, but also in situ thrombus is a real common issue that can be mistaken for. So the presence of clot does not mean it's chronic. It does not mean it's the cause of the PH, and it does not mean it's the cause of the actual patient's functional limitation. Now, on the left side, these concepts really depend on the individual program and experience, but the concepts are, can we access the clot surgically, anatomically? And I'll show you what I mean by that in a second. And on the bottom, absence of comorbidities, age, BMI, renal function, but these really depend on a single center's experience. When I look at my program today, patients I might have said no to 8 years ago, I would absolutely say yes to today. So this is a spectrum, and I think this is a really important patient safety thing to recognize. And I've worked at a place that did this after I left it. I kind of learned the hard way, so very humbled by this concept that what is surgically accessible or what is a comorbidity that may or may not be a limitation one place may be at a place that just doesn't do a lot of it. I know you all do a lot of heart transplant, for example, and you can probably relate to the same concept of, sure, we can take this high-risk patient about a certain age with this creatinine, and because we've just done this a lot and we've gotten good at how to manage that over time. Patient consent and motivation is important, of course. And it's worth mentioning in the context of PTE because ambulating quickly and being kind of proactive with rehab and physical therapy and incentive spirometry and all of the things, there's not a lot of respiratory and pulmonary reserve immediately post-operatively. So it's even more important in this population than even my heart transplant or VAD patients who are very sick as well going into surgery, but I've come to be humbled by this. Now, just some semantics for a moment. This is pulmonary embolectomy. This is red, fresh, acute clot. This is a patient referred to me that had undergone lytics elsewhere. And so a lot of clot is broken up here. And of course, everyone knows in the middle, this is the thing that makes us pause and say we should probably take this out before it causes a huge stroke as it's trying to go across the PFO there. But this is acute clot surgically removed. This is an embolectomy. I'm not a surgeon. I'm not going to pretend to say this is easy. That would be an absurd sentence for somebody like me to say. But relatively speaking, it is compared to what we're talking about here today, which is thromboendarterectomy, pulmonary thromboendarterectomy, which is PTE for chronic clot. So I hope you can kind of gather that, first of all, there's a wide variety of what this might look like in terms of unilateral or bilateral involvement, proximal main PA, complete occlusion versus segmental, lobar, subsegmental, and distal. It's fibrin, it's chronic clot material. It's this rubbery white material. When you see this red stuff, sometimes there may be some acute on chronic, but when you have complete occlusion of a proximal large pulmonary vessel, we call these pouch defects, you get a lot of stasis and turbulent flow within, and it can have that brighter appearance. This is all chronic clot. It's a very different appearance. It's a very different surgery. Technique, I will just quickly describe why it's different. It does require deep hypothermia and circulatory arrest. The severity of pH will increase the risk of doing this surgery. This on the right just kind of shows that the circulatory arrest component. But it does involve incising the central pulmonary artery. Sternotomy, of course, is the standard of care, and then gradually dissecting into every single branch of the pulmonary circulation, of which, as you know, there are countless numbers, and each time requires circulatory arrest. And there's a limited number of time that you should circ arrest, and then you stop or you reperfuse, and then you can arrest again. And it's a very long process, and the technique is quite complex. Post-operatively in the ICU, because these are patients that were chronically occluded in perfusion, when they reperfuse, it can cause dramatic lung injury. It's expected, but it's life-threatening. And so the reperfusion lung injury can sometimes lead to the need for emergent BV ECMO. This is one of the major causes of peri-PTE mortality. Bleeding risks are much higher in this population because they mandate anticoagulation therapeutic early because they are clotters. The hemodynamics of right heart failure, severe right heart failure going into any cardiac surgery are complex. And so that is part of the nuanced management post-op. Circulatory arrest causes significant impairments in neurologic function relative to most of our other cardiac surgeries. The management of sedation, arrhythmia management, and right heart failure are all a little bit more nuanced. I come from the background of VAD and transplant and advanced heart failure, and I love that. And I very much respect and love taking some of the sickest patients in cardiopulmonary disease to cardiac surgery. I have to say I've been very humbled in how much more complex these PTE patients are relative. I thought I had kind of seen it all and done it all with my VADs and transplant, but there's just some layers here that are really interesting to learn about and keep us humbled. Now, in terms of outcomes and expectations, this is our data from our Temple program. Earlier in our program, at this point now, we've done over 425 cases. We do about 60 to 70 PTEs a year. From your institution, I just reviewed one of your cases 2 nights ago, so we can chat later about whether that young man is still taking his Coumadin, because I think he is not, but that's okay, we're scheduling him for PTE soon. But in our early series, these are just some examples of proximal and distal disease. but we're really happy to show clinical outcomes that are relevant to us as cardiopulmonary doctors. Resolution of pulmonary hypertension, resolution of pulmonary vascular resistance abnormalities. We're the only program, certainly in the United States, and one of the only in the world that looks very carefully at echo Doppler in terms of serial follow-up. So we've demonstrated normalization of right heart parameters in terms of size, structure, function, improvement in 6-minute walk, BNP, jugular venous pressure, oxygenation, functional class. And I want to show some other experiences in some of the other modalities, but I mentioned the program experience, of course, does matter, just like in transplant programs. But interestingly, in the guidelines, it will say if you are a PH program and you see a patient with CTEPH and you deem them to be inoperable for any of those reasons I said, age, comorbidities, it's too distal disease, the guidelines actually say that you can't decide that definitively until you've referred and had that case evaluated by a high volume expert CTEPH center. And this just comes from many years of study design that made us learn that medical therapy of disease that is operable in the hands of experts doesn't work. And so the guidelines sort of say, are you sure? And thankfully, we have more and more real pulmonary hypertension expert centers around the country than we did when I started my career. But they will be the first to say that pulmonary hypertension centers of excellence does not equate to CTEPH centers of excellence, but thankfully we're a small group and we're all connected and we all know how to get patients where they need to be. And then a conundrum is that patients with more severe hemodynamic impairment, the worse your pH is, the higher your perioperative mortality is. But that's also the patient that would derive the most benefit and the life-saving intervention of a PTE. So these are just some of the concepts that tie into how the volume and experience of a center can really matter. Now, postoperative management and care after PTE. Just quickly, a big question often comes up immediately post-op. What are the pulmonary pressures? Is the pH cured? Because we always say this is the one form of pH that can be cured with PTE surgery. But all of these parameters on the slide here, I won't read them all to you, all can impact the steady state immediately postoperatively and impact the degree of pulmonary hypertension. So we pay attention to what those pressures are postoperatively, but it's not the end all be all. And we're the only big volume CTEPH program in the US that follows our patients for months and years thereafter. And we've really just tried very hard to learn from that serial assessment and what should we be paying attention to. And so we published this sort of guide in the last year or two, basically saying the steady state, give it a few months. We see everybody at 3 months post-op, as well as a week or two post-op. But keeping into account all of the historical things that happen normally in post-cardiac surgery that might affect a patient's functional capacity that I've listed here. We'll do a 6-minute walk, not just how far can they walk, but are they augmenting their blood pressure with exercise? How much are they desaturating? Clues of residual disease? What's their right heart failure or physical exam at this point? Of course, biomarkers can be really helpful. And then looking at the echo Doppler in detail. What we're getting at here are post-PTE, how do you know if a patient has adequately fully responded? Do they have any residual disease pH that might warrant further intervention? Some of our data looking at the echoes post, interestingly, the things that predicted in our experiences what patients that were more likely to then derive benefit from balloon pulmonary angioplasty or medication, which we'll get to next, were things like right heart size, shape, structure, function, the degree of TR, Doppler abnormalities in the RV outflow tract that represent high pulmonary vascular resistance, but interestingly, not the degree of pH on echo. That's a whole conversation for another day, but in the whole world of pH, the RVSP estimation is probably the least specific and least helpful as a guide in terms of the status of a patient. Now, this patient I mentioned to you earlier, this young man with very severe pH, being evaluated for hospice, ultimately came to see us. And I just wanted to show this is the clot that we were able to remove from his lungs. The large right atrial clot, tricuspid valve, calcified mass throughout, and just happy to report that despite his severe cirrhosis and end-stage disease and multi-system organ failure, was able to benefit from this intervention and cure. And happy to say now, about 2 years later, is doing very well in functional class 1 and resuming a normal life. Now, Shifting gears into balloon pulmonary angioplasty, this is a much smaller component of the CTEPH world. I want to just give you kind of a journey through the history of this and where we are today. Balloon pulmonary angioplasty, extremely different than coronary intervention. The vessels are tiny and there's a million of them, not quite a million, but you get the idea. This is reserved for folks that have smaller vessel disease, more distal disease, or maybe post-PTE with residual disease. This is just some examples of what that looks like. This is not stent deployment, it's pure balloon angioplasty. And pre-PTE, or pre-BPA, excuse me, the picture on the left is our cartoon. You'll recognize I showed you a path picture of that before. We're not removing clot, we're simply moving it out of the way. So there is a little bit of a difference here in BPA intervention relative to PTE where it is actually removed. This was initially described in the 1980s. Small series, good clinical results hemodynamically and functionally. However, there was too much of a risk of severe pulmonary lung injury, positive pressure, ventilation and intubation requirement, and death. So this did not take off. Fast forward now, about a dozen years ago, the Japanese group, Matsubara, really leading this, reported a more refined technique of balloon angioplasty using intravascular ultrasound, more direct vessel assessment with imaging to try to avoid some of the vascular injury that was happening previously. Still a smaller series, but much improved outcomes, improved hemodynamics, and a more acceptable risk profile. And so this kind of, the last dozen years, this has now taken off. We're in the current era of balloon pulmonary angioplasty. Very briefly, I want to just show you some of the worldwide experiences here to give you a sense as to, well, what is really happening and what are we getting out of this? So this is a larger Japanese experience. 84 patients, 424 balloon pulmonary angioplasties over 7 years. All patients were inoperable, so they were assessed for BPA instead. All anticoagulated, of course, all treated with anticoagulation. And just quickly, notable improvement in hemodynamics, believe it or not, pulmonary pressures, PVR, functional capacity with 6-minute walk, BNP falling, and improvement in the need for PH medical therapy and supplemental oxygen. Survival benefit as well. That was the Japanese experience, and with a really improved and acceptable risk profile without mortality. This is the French experience, over 1,000 BPA sessions, and they've also demonstrated in large volumes notable hemodynamic improvements with pulmonary pressures, cardiac index, PVR, appropriate and acceptable sort of risk profile in terms of vessel tear, bleeding, hemoptysis, reperfusion lung injury. And then I just want to share with you, we also published our data last year in JACC Advances and our experiences with balloon pulmonary angioplasty. And we're using a very refined technique while we're doing this, using angiography, but as well as pressure wire assessment pre and post lesions to help guide physiologically, not just anatomically, targets for therapy. Our risk profiles are very low in terms of intubation, vessel tear, hemoptysis, but we are demonstrating significant improvements in hemodynamics, 6-minute walk, BNP, and pulmonary arterial compliance. And we are also now looking at patient quality of life questionnaires that are also showing really wonderful results. So the BPA world is really evolving nicely. And for those interested, very recently, a large updated kind of first ever European consensus statement on balloon pulmonary angioplasty. So if you're curious, this just came out within the last 6 months or so. And they show also some examples of the types of vessels that you might target. And they really also do emphasize the importance of a multidisciplinary kind of team for this and demonstrating in a couple of randomized large trials, multi-center hemodynamic improvements from BPA. One of the most important things for BPA is to just emphasize it cannot and should not replace PTE. The field is simply not there yet for some of the hopefully obvious reasons that I mentioned in terms of what the intervention actually involves. And so BPA, there's not really such a thing as a BPA program. It really is a component of a CTEPH program. It would be like having a transplant program, but not offering VAD, maybe as an example, if that makes sense. You sort of want to have the whole host of advanced therapies for a patient for the disease, and then be able to offer what the right intervention would be. So towards the end here, the PH medical therapy, very quickly, these are all of the medical therapies available for PH in general, PAH, but just honing in on riociguat. It's a soluble guanylate cyclase stimulator. It works via cyclic GMP and nitric oxide. It was first published about 11 years ago now in the CHEST-1 study. So it's novel class, novel indication, the only drug approved to treat CTEPH, but only if it is inoperable or recurrent after PTE. And many other drugs have been studied and looked at, so it's worth just being aware of in the ERA category. Macitentan, our most recent ERA, which is now over a decade ago, was studied in a smaller study called MERIT, 80 patients. It was a positive study, again, in inoperable CTEPH, but it was a very small study. So the data are very favorable, but it did not achieve FDA approval. But just be aware of the positive data to support its use if you need to as a second-line agent for this scenario. Now, I promised I would mention at the end some clinical diagnoses that might mimic CTEPH. Really important to be aware of the possibility of pulmonary vessel sarcoma. Can look just like proximal CTEPH, often involves pulmonic valve or RV outflow tract. Tumor emboli from a whole host of solid tumors have been described and can really surprise you and look like CTEPH. Fibrosing mediastinitis can also look like thromboembolic disease. You may see calcifications or a history of histo to kind of corroborate that diagnosis. In situ thrombosis, congenital heart disease, because the shunting in the very large vessels, or patients with really diseased fibrotic advanced lung disease, they're very prone to abnormal flow mechanics and they're more likely to develop in situ clot. They're also at their own risk for developing significant pulmonary hypertension from either PAH, from congenital heart disease, or lung disease PH. So this is a very common confusion of in situ clot in the context of a comorbidity that also causes PH. Sarcoidosis can, of course, mimic CTEPH by multiple degrees of mechanisms, and then vasculitis as well. Everybody here in some capacity takes care of dyspnea, and CTEPH can feel very complicated. This is just a 1-minute video, if you don't mind, that a patient sent us that is on one hand extremely very simple, but I hope we can all relate to in terms of what we are all doing this together. So I'll just play.
Pictures the hill is like 50 to 60 yards tall. It's steeper than a 1212, which is steeper than most roofs. I haven't been able to walk straight up this hill since before Dr. Toyota did the open heart surgery. So here we go. Straight up. I'm gonna lose my breath at the top, but between the pictures and this, you've been looking for context. I'm starting to get a little short of breath, but I'm still going straight up. I definitely couldn't do this for a long time. Here I go, I'm at the top. There it is, the end. You can hear my breathing, but not bad. Just the fact that I was able to do it, I have to thank you guys tremendously. See you Tuesday, bye.
See you Tuesday for my follow-up visit. Very simple, but I think we can all, no matter what we all do as cardiopulmonary doctors, to relieve a patient of dyspnea such that they're like, I can walk up this hill and I couldn't do it for a long time. It's a really gratifying field to be able to be a part of. And so with that, I just want to acknowledge my whole team. It takes a whole village to take care, a small army really, to take care of these patients. Multidisciplinary, interventional cardiac surgery, PH medical cardiology expertise. We are extremely honored and humbled. We've taken care of patients from other countries and over 26 states in the US, the whole like East Coast and Mid-Atlantic. We're really honored to be trusted with the care of your patients and so many others. It's really been a pleasure talking to all of you today. And I want to also thank the folks, the family supporting the Diane C. Wallerstein lectureship in the spirit of education, which I know this lectureship was supported for. Just a small plug, if you don't mind, for we have one of only 5 advanced pulmonary hypertension fellowships. So you have wonderful trainees here. If any of your mentees, pulmonary or cardiology, are interested, please don't hesitate to reach out. So thank you so much for your attention. I think we have a couple minutes for questions, if there are any.
Thank you so much, Dr. Vaidya. It's wonderful to hear about advancements in CTEPH. I mean, I know it's a lot of people here. I think everyone probably learned something new today. It's such a specialized field. We'll start with Dr. Vetrovec, who has a question here.
What's the restenosis rate on the pulmonary dilatation?
So balloon pulmonary angioplasty, good question. What is the rate of restenosis? It's very low, interestingly. There's not much in terms of the way of vascular recoil, and it's partly why we measure compliance also long-term. So with not just in our program, but now with years of long-term data, thankfully, that is not a problem. Yeah. Yes, question.
Thank you. That was a really excellent talk. I have a question for patients you're taking into your program. And I'm certain we're missing this diagnosis, or we have patients kind of lingering for years. How much faith do you have in the diagnostic testing that's coming in with transfer patients? So if they've had CT scans done, they've had VQ scans, do you accept the report and the technical imaging, or do you have to repeat everything?
That's a great question. So the question is, for all the referrals that come from elsewhere, how do we handle the data that's been done locally versus what do we rely on? So the way our program runs things is we review the scans, the primary data of any patient referred. So if you were to email me or call me or text me and say, listen, I think I'm seeing CTEPH, can you help out? I would say, great, that's all I need to know. Send me and I'll tell you how and where. Whatever images, CT, VQ that you've done, if you haven't done them, do them, but it's always the image evaluation. And the reports are fine, but we read everything directly. The reports are not adequate enough. So you should do locally here your VQ and CTA and echo at the minimum. Diagnostic right heart cath, I'm sure will be done along the way as well. Catheter-directed pulmonary angiography, don't bother. We will virtually always do that on our own because of some of the nuances and complexities in interpretation. And depending on what we see with your VQ and CTA and the timing of when they were done relative to the referral, we will decide on an individual basis if we need to repeat them at all when they come and see us. So I hope that helps answer your question. So, do the CTA and VQ and echo, send them to us, we'll review it. After we review everything, then we will call your patient and schedule a coordinated visit based on our review of the case that may involve a visit with me, a surgical office visit, a diagnostic pulmonary angiogram, and an OR date for a PTE. So we make it very, very easy for the patients, and we help them with travel arrangements too. Our residents are travel. They're like, oh, welcome to Temple. What state are you from? What hotel are you staying in? And when is your flight booked to go back? And it's just a pretty well-oiled machine now. So
Just one more question.
Yeah.
Do you guys have, an appeal process to work with out-of-state?
Oh, it's never a barrier. So don't let that, thank you for asking that. Out of state, because we are one of the biggest programs in the world, we've always been able to navigate getting that approved for the specific disease state and what we do. And we will guide you. Some of it has to be submitted on your end, and then we will guide exactly how to do that. So thank you for asking that. That's a practical point. Yeah.
Can I piggyback on that?
Yeah.
So there are other CTEPH centers that are closer, and we refer almost exclusively to Temple because of their experience. So it's not just any CTEPH center, it's Temple or UCSD is the only two that the PH group refers to.
Yeah. The volume, this has been a journey for us too, and we have not referred anyone out, I will say.
Yeah.
So there's no program that will take a patient that we wouldn't in terms of experience. And we really, once you're a CTEPH patient of ours, we're like, you're kind of part of our family, you're a major VIP, and we will, do our very best to get you through this. And our outcomes are amongst the best in the world. Yes.
Do you see any reverse RV remodeling in follow-up, improved function, or is it
It's beautiful.
Okay.
It's amazing what happens when you take a RV that is under a severe afterload limitation and immediately reverse that. It's similar to end stage PAH or lung disease PH going through lung transplant. The RV is dysfunctional on the basis of afterload. It is not intrinsically having a myocardial contractility limitation. So when you relieve the afterload, that RV is actually a hypercontractile RV. It is dysfunctional, but hypercontractile. So it's a beautiful thing. So when you select the patients correctly, in other words, it is CTEPH, it's not in situ clot, it's not congenital PAH. When you select them correctly, the result is beautiful. And it keeps us going. It's really hard to take care of these patients, but the outcomes are very satisfying when done well. Yes.
Thank you. This is excellent.
Thanks.
You see more CTEPH in patients who discontinue anticoagulation after PE or lifelong, or it doesn't matter?
Thank you for asking that. So the question is, if they discontinue anticoagulation, do you see more CTEPH? So yes, that is the biggest risk for recurrent CTEPH, even after a PTE. So, we can cure their PH, but it is lifelong anticoagulation. Somebody's now wondering, is it DOAC or is it warfarin? So let me just address that next and say this is a global debate that it's not been resolved. Certainly in the antiphospholipid population, warfarin, you have to, that is very evidence driven as being better. It's quite possible that it is also better in the whole population of CTEPH than our DOACs in the short and long term. That said, and this story is evolving and my answer to the question has changed over years. Patients and physicians, you just can't get them to do warfarin across the board in the current era of DOACs in all patients. And so the bottom line is stay on anticoagulation forever. If you have antiphospholipid, definitely warfarin, and a little bit of a gray zone in terms of which kind of agent to use in the rest of the population. Yeah, sure. Yes.
So you mentioned, that was amazing. Thank you for
Thanks.
coming and giving us a talk. I think you mentioned briefly, riociguat is never a alternative to PTE, but when at the time of referral, as soon as we've diagnosed,
Yeah.
our practices will start riociguat instead.
Yeah.
Is that?
I think that's the practical reality.
Yeah.
So patients may be hesitant to make the trip. There's often in real life some time in between. So that is the pattern that we're seeing more and more. Now, there's a phenotype, big category of patients with CTEPH who have such occlusive and proximal disease that they will have no benefit from riociguat. If anything, they will have systemic hypotension, peripheral vasodilatation in the context of proximal occlusion, and they will actually feel worse.
Okay.
That may happen, but I'm not going to tell you not to try it. If your PH instinct says, let's do this to get you there, then that's fine. But you won't hear us say, this is a surgical candidate for PTE. We're going to give more time on riociguat before we take them. Yeah, it's a really good question.
Well, thank you guys so much, and thank you, Dr.
Yeah,
Vaidya, again
thank
for making
you.
the trip down here.
It's so great to
We'll
be here.
certainly continue our collaboration between VCU's PH
Yes.
team and working with Temple, and yeah.
Feel free to, I was going to say, many of you have my cell phone number, so you can share it, my email address. If you ever have a patient, if we can help, we're happy to. Our CTEPH meeting is every week. It's long. We have a lot of patients to review, but you don't have to ever join us. But if you ever really wanted to be there when we reviewed one of your cases, we oftentimes will coordinate that just if you're interested and for some teaching. So we can do that too. So
Great.
if anyone ever wants to do a rotation, you're welcome. You get the idea. Thanks for having me. It's really great to be here.